the Shelbourne East Center podcast. This is Dr. Benner. I'm here with Scott Bauman, and tonight's episode is going to be another interesting discussion, a little bit of a different topic, as we're not necessarily discussing specifically a surgical or physical therapy topic. We're talking more about ethical considerations and things like that in orthopedics, and we'll talk a little bit more about that topic here in a bit. But I'm excited about our guest that we have tonight, and I think it's going to be interesting content for all of you that are listening. If you want to hit us on social media, we have Twitter and Instagram at the SKC Podcast. We have a Facebook and YouTube channel as well for the Shelbourne East Center Podcast. If you need to contact us, which we'd love to hear any questions you have, you can send that to the skcpodcast@gmail.com. If you want to catch any of our previous content, you can find us on any podcast avenues at the Shelbourne East Center Podcast. Leave us a 5-star review if you like what you hear, and check out our previous episodes.
And speaking of previous episodes, before we get started tonight, just wanted to go over the recap for last week. We talked with Dr. Catherine Harper from the DC area. It was a great conversation. We talked about intraosseous medication delivery for total knee replacements, and it was really a cool topic, and it's one that I have not really had any experience with. And learning from Dr. Harper was really fascinating in terms of what they're looking at from a research perspective and what kind of outcomes they're getting with that. So go back and check out last week's episode on intraosseous medication for total knees.
Tonight, we're discussing an article from the Journal of Bone and Joint Surgery, another JBJS article from their orthopedic form section, where we found ethical considerations of declining surgical intervention, balancing patient wishes with fiduciary responsibility. And the first author on that, Dr. Claudette Lajam, is here tonight from NYU. She is a joint replacement surgeon from NYU. She's fellowship trained. Actually, we've learned now in talking before we started here that we did the same fellowship at Insall Scott Kelly. She did residency at Mayo Clinic before that fellowship. She's now a professor in the Department of Orthopedic Surgery at NYU School of Medicine. She is also the Director of Quality and Safety in the Division of Adult Reconstruction, and she is also the Quality and Safety System Chief for Orthopedic Surgery. So, Dr. Lajam, thank you for joining us tonight on the Shelbourne East Center Podcast, and we're glad to have you here to discuss this topic.
Well, thank you so much for having me, Scott and Rodney. This is really an important topic, and it's very interesting to me. So I really appreciate your giving me the opportunity to discuss it with you today.
Let's jump right in. How did you get interested in this topic? How did you become a part of this, the generation of this manuscript, and how did you become an expert on this to write for all of us to read about?
Well, I'm sure a lot of us have been faced with these situations where we have patients who are very, very high risk for surgery, and we then perform surgery, and then something really bad happens. And then we look back on it and we say, wow, okay, maybe we could have offered them something else, or maybe we could have declined, or we could have done something else. And now that it's oral boards time, a lot of our young surgeons are thinking about those things right now. So I think it's absolutely appropriate, because indications are the most important thing we do. We can be skilled surgeons, we can be technically amazing, but if we don't select the correct patients to operate on in terms of risk benefits, balancing the risks and the benefits of the operation, I think then that's how we fail. And that's how we should train our young surgeons, is to make sure they understand when operating is the right move and when it's not the right move. So the genesis of this paper came about because as you said, I'm the system chief of quality and safety for all of our sites, and I see everything that goes wrong. So when something goes wrong, I see it. And Joe Bosco, who is our vice chair of clinical affairs and former president of the academy, he and I discuss them frequently. We discuss these cases and say, oh gosh, should they really have, done this at this time? Now, obviously hindsight is 2020, but we look at these cases and we're constantly discussing them. And we said, you know what, we should do a department meeting and discuss these challenging cases and the ethics and how we balance them, how we balance informed consent, how do we have a discussion with patients, what are the barriers that we face, and what are the ethics of this? So we decided to have a department meeting, and we discussed all of these things, and we invited one of our medical ethicists, Dr. Baron Lerner, who is an expert on the ethics medical care. And we sat at a round table and we had a really robust discussion in person about a bunch of cases. And we said, we should really write about this, because I think this department meeting was really beneficial for everyone that was here. It generated a lot of discussion. It generated a lot of discussion after the department meeting. And we thought we wanted to extend that benefit to the readers of a journal, that if a journal wanted to publish it. So that's really the reason we did that. And we do have a history of publishing on medical ethics because we do have a robust medical ethics department led by Art Kaplan, and he's a pretty well-known medical ethicist. So we've written a few papers before, especially when value-based care became prominent. We debated the ethics of value-based care. So that's a long answer to a short question, but there's a lot of background there.
Well, I'm glad that you bring this topic up, and I'm glad that you wrote this article, just because there's just, we spend so much time as surgeons, and Scott and I just returned from the AOSSM meetings, the summer sports medicine meeting, and there's just so much talk about surgery. There's so much talk about surgical technique. What surgery do we do? How do we do it? What are the outcomes from that surgery? What are the pitfalls of that surgery? But there's very little discussion at that meeting. And it's not to impugn that meeting. I like that meeting, but the academy meeting, the ACUS meeting, the same kind of things that people are just talking about surgery, and there's just not much discussion on who are we actually operating on, who are we providing non-surgical care to, what are the best the pearls and pitfalls that we can give people better non-surgically. It just seems like an area where we as orthopedic surgeons could really get better and put our patients forward of our surgical volume and our surgical techniques.
And that's a great point, because we are, and now that our pay as surgeons continues to be decreased by congressional and regulatory decisions, and I know that's in the news and all over social media now, we are really pushed to do more procedures, and it's more difficult to not do them. We have to be able to support our practices and our institutions. So a lot of our thinking is shifting because we need to be able to, keep up with the volume of patients. And a lot of the time we need to pause and consider the whole patient. And some of our patients really aren't good candidates for surgical intervention. And when are those patients better served by not having a surgery? Yeah. Well, and that's a big decision we need to decide about.
Yeah, so you jump into that in the manuscript, which I was happy about that from the very beginning, when you talked about the medical, the legal, the financial, and fiduciary environment that really surrounds this topic. So before we even jump into that, just discuss a little bit about those kind of backgrounds of the environment that we're all practicing in, and how that kind of sets the stage for starting to think about these things in a different way.
Well, absolutely. I mean, U.S. News and World Report just came out this week, today actually, and we're number 3 in the nation. NYU, go NYU Langone. But a lot of those metrics are, thank you. A lot of those metrics are based on mortality and volume and all these things and hoops you need to jump through. And I think sometimes we get blinded by these metrics that we have to meet, and there's more than one set of metrics. Medicare has a readmissions metric. I mean, there's lots of different things that hospitals and surgeons are graded on with regard to what we call quality, but what we really mean is compliance. We want you to comply. We want to keep costs down. So we want you to comply with what we think is quality. And it's very, very difficult sometimes to navigate that. So there's a lot of pressure. And also we have the legal environment. In the US, we have the most aggressive legal system in the whole world. And in some states like mine, it's extraordinarily aggressive. There's almost no limit on what can happen to you as a physician. Even if you do everything you should do, you can still be sued and lose everything depending upon the court you're in. So there's a lot of things you have to consider as a doctor when you make these decisions to operate on somebody.
Really hot topic at the sports medicine meeting. Just out a couple high-profile cases with multi-million-dollar judgments against orthopedic surgeons for what I perceive as some pretty straightforward decision-making in the operating room that we make all the time. And, I hear those talks and I want to be educated on those, but it scares the hell out of you to think about those. This professional athlete comes into my office, wants an ACL reconstruction. Sweet. I get to do this big time athlete's ACL reconstruction. But what kind of,
what does that open you up to?
I open myself up to, how am I putting myself at risk versus I would get paid the same doing their ACL as I would yours or Scott's or anybody else's. And it's just a kind of an interesting time to be doing what we do in particular. And hopefully the people at our societies and our academy continue to work diligently to try to make that environment better. We're pretty lucky here in Indiana, to be honest with you, that our malpractice environment is much more physician friendly. We have any kind of a suit that gets brought by a patient has to go to a medical review panel of physicians before it even for them to give a recommendation before it can get to the operating room. That doesn't mean they can't bring the suit if they don't want to, despite the fact that the physician panel says that it doesn't hold water. But it gives us a layer of review if that were to happen. And I understand the environment's not like that in other states.
New York is a frightening place for physicians, and that's why we train everybody and we retain almost nobody here, because the environment here is absolutely ridiculous in terms of you don't even need an expert in your same field to be an expert witness against. And on the plaintiff side, the plaintiff's expert doesn't need to be board certified here, and pretty much anybody can sue anybody, and there's unlimited liability. There's no limit on anything that can happen. So you can lose everything. You can lose your house. You can lose your kids' college tuition, and it doesn't even mean that you did something wrong. It's just a bad outcome can do that, because your jury is a bunch of lay people, and they don't understand medicine. They don't understand surgical decision making, and that's what the plaintiff's attorneys rely on, is that they don't understand that you have a jury that you can manipulate to think that someone did something wrong when we absolutely didn't, just because we are doctors, and it's a different world that we live in here. So there's no way for you to have a fair trial as a physician in New York.
Long topic for another day, not exactly the focus of this
we
paper,
can talk about this forever.
We can talk about that one all day.
Yes. The one thing that I do recommend, though, is if you are a member of the academy, that one of the most beneficial things you could do is become a member of the PAC, the Political Action Committee, because that does a lot of good work. We have some fantastic people leading that. Wayne Johnson is now the PAC chair, and Adam Brueggemann is the Council on Advocacy chair, and they're both really dynamic hustlers. They hustle. They make it work. They make it happen. They're amazing. So you've got a really good team working for us there. So it's worth an investment into the PAC if you haven't already joined.
Now, going back to the origin of this manuscript, you talked about a staff meeting, and the three aspects that we were just talking about are pretty heavy topics. We're talking medical, legal, and financial implications as it relates to the care of patients. Now, when you said that the impetus of this project was a staff meeting that you had, what was that like in terms of who was there? I know you said that it was a really robust discussion, but was it only orthopedic surgeons? I know you said there were some ethical experts as well, but as far as other members of the medical center or anything like that, can you go into a little bit more detail about what that looked like? And you don't have to get into that much detail about the exact conversations, but just the overall tone and who was maybe involved with those decisions.
So we have a very large department. We have almost about 250 orthopedic surgeons in our department. That's, very, very large. And except for during COVID when we couldn't, we have live in-person department meetings. And I don't know who else still does that, but we do. And that room is packed. There's standing room only for these meetings. And we have some guest lecturers, and they come in the door and they just can't believe how many people are there. They're taking pictures, to send to their chairman to say, wait a minute, look at this. There's actually 250 people here. But so and that also includes some of our physician extenders, our PAs, nurse practitioners sometimes come to these meetings. We do have affiliated faculty. For instance, one of our vascular surgeons was there that day. But the ethicists we invited it specifically to come to the meeting. Our residents are also at the meeting. So it was a really good conversation, because we spanned topics on a bunch of different specialties. And in the article, we changed a lot of the details about the patients to protect their privacy, but the general idea of the case was the same. And we had a sports type case, we had a spine case, we had a total joint case, we had a fracture case, a wrist fracture, and all of those patients came to an orthopedic surgeon one way or another, and had there was an ethical decision that was made when surgery was decided on, and outcomes were, not so great in most of the cases. And in one case, it was not so great, but the patient wanted to have their other side done after that. So you have to really understand that, what's informed consent? How do we talk to our patients? So our department is kind of used to, we're New Yorkers, most of us, we are pretty vocal. We don't hide what we think. So there was a lot of discussion and people speak up and say what they think. So there were some people that thought that, how could you possibly say this? That's crazy. How can you deny a patient surgery? You're cherry picking. And then other people on the other side say, we need to do this more. You're telling people you're going to help them and you're really not going to help them that much and you're putting them at risk. So there was a lot of debate and it was pretty passionate, actually.
So obviously that robust discussion led to this paper and talked about the aspects of medical ethics. And you really talked about the 4 aspects of beneficence, nonmaleficence, patient autonomy, and justice. Before we get into the nitty gritty details here, can you just go briefly over those 4 aspects and tell the listeners what you meant by those 4?
Well, sure. These are pretty well established. So there's 4 basic tenets of ethics, of medical ethics or ethics. And you just said what they are: the beneficence, non-malfeasance or non-maleficence, patient autonomy, and then the question of justice. And then we added our guiding principle that there's a primacy of patient interest, meaning that you have to put the patient first when you make these decisions. So basically, we'll go through them all. So beneficence, and like it sounds, what we do should improve well-being for the patient. And I can talk about a little bit of the controversies about what that means, because well-being for us might not be the same thing as well-being for them, for the patient. So we want to make patients better. So that's what we consider well-being. But patients think, okay, what's going to make me happy? What's going to make me comfortable? And they may not think about the bad things that can happen. They think, oh, I want this carrot that you're dangling in front of me. So beneficence may mean something to you that's different from what it means to the patient. And then the second question, and that ties into the first one, is a non-maleficence or non-malfeasance. And that means that don't hurt someone. Do no harm. What you do should not cause harm. But times a patient would rather die than live with a painful condition. So they think the harm is denying surgery, whereas you consider harm that they might pass away or die because they're high risk for surgery. So there's a lot of things that we have to consider when we think about what is harm. And then the third thing is patient autonomy. So what that really means is not that patients should be able to do whatever they want, but that when they make decisions, they should be allowed to make decisions without influence that's high pressure to them, that they should be able to make their own informed choices. Doesn't mean they're always going to get what they want. As we all know, a lot of people don't make great choices, and that sometimes lands them in a position of needing one of us, especially trauma surgeons. And then finally, the concept of justice. And that goes back to the concept of the tragedy of the commons. We have limited resources in our society, and that's become very, very obvious in the past 15 years since we started instituting value-based care and trying to look at what things cost and the cost-benefit relationship of anything that we do in medicine. And the tragedy of the commons means that if there is a limited resource, we need to protect that resource. And you need to know that when people have access to a public resource, you don't want them to have to deplete that resource. And this goes back to, you see even in England in the NHS, if their region runs out of money, they can't do any more surgery for that time period. That's just how it is. This is your budget. If you run out of money, you can't do anything else. So it's very real. So if you're going to operate on a high risk patient and have a bad outcome and spend a lot more money, you can't treat 10 low risk patients with that same resource. So these are real questions that we have to think about when we're doctors. And most of us just want to know, oh, do you need a knee replacement? Oh, do you need a rotator cuff repair? Oh, you broke your wrist. Let's fix it. Whereas, we don't want to be thinking about all these questions all the time. So it's very hard sometimes to think about all these processes when we're talking to our patient.
Yeah, I thought that was really interesting the way you laid that out in the manuscript that we're referencing from the Orthopedic Forum and JVJS. Go read it. Where you talked about the kind of intermingling of the high and low risk patients, and how taking care of high risk patients could potentially deplete resources that could be used with low risk patients, and vice versa. That it doesn't mean that the high risk patients aren't prioritized. It doesn't mean we shouldn't operate on high and work on and try to make better high risk patients. It just means we have to look at that in the context of the medical system as a whole. And after reading about the experience in England, I'm glad that I don't have to think about those kind of things as much as maybe other medical systems do, and that we're not dealing with quite as limited a resource. But there's a couple things that you said that I think are specifically interesting as we relate it to joint replacement, which you and I do. I'm just a knee specialist. I do sports medicine and joint replacement, probably 70-30 adult reconstruction to sports medicine. So I do a lot of total knees. And where I think about some of these concepts is bilateral surgery and outpatient surgery. When it comes to bilateral surgery, I've had several patients that have come to me and say, well, I came here because the other surgeon told me I can't do both my knees at the same time, and I'm hoping you'll say that I can do them at the same time. That's really the only reason I came here. Wow, interesting. Okay, honesty, I like that. Very good. But
well, you know what, Ronnie, try being a woman surgeon. Because they think, oh, the woman's going to be nice to me. If every other doctor says no, she's going to say yes because she's a woman and she's going to be nice. So it's it's kind of it's definitely a real thing.
Yeah.
Sorry to interrupt.
That conversation's always interesting for me, because when I ask friends that say, yeah, I don't do bilaterals anymore, really, why not? Well, we only get paid half for the second one, and it's a longer operation, and it kind of wears me out. And, people stay in the hospital longer, so I have to round on them longer, and, blah, et cetera, et cetera. And the same similar things with outpatient surgery. I had a friend recently, he's like, hey, man, you do these as outpatients, you don't have to round on them anymore. You get there's not as much a burden on your staff to come around and take care of things in the hospital, et cetera. And so you can do them in the surgery center, and you're potentially an owner in the surgery center, so that benefits the surgery center and you financially. And in both of those, I get frustrated with those. Like, there's a lot of things that are being thrown at me that benefit me. Where do we talk about the part that benefits the patient? If there's somebody that has two terrible knees and they have a low medical risk profile, and they say, I got 3 months off of work and I got to get back to work, I don't have time to do two separate operations. That there's some specific situations where I think bilateral surgery is the best thing to do. So
I have no trouble doing that.
To just summarily say we don't do that because it doesn't benefit me, I think is just it. But I don't know if it violates these tenets of medical ethics that we're talking about, but it seems to be in the face of the spirit of these type of ethical considerations.
Oh, of course. I mean, and that really actually violates that whole fifth, tenet, the primacy of patient interest. If it's not, I mean, again, we know that double knee replacement is a higher risk than a single knee replacement. In general, it's a bigger operation. But if the patient is healthy and there's a real benefit for them to do both at once, and I think, severe deformity, flexion contractures that are substantial,
Absolutely,
because it'll impede the healing of one to have, a problem with the other. I have no problem doing that for the right patient, but I do have some pretty substantial parameters in terms of what I say to patients for that. And the first thing I say to them is, well, you're going to feel like you got run over by a train. You think we are much better at this pain control after surgery, but, this is a big hit.
I used to be a therapist in our office, and I would say to all of those patients, listen, a lot of my patients come back and say, my knees are doing okay, but I'm hungry, but I don't feel like eating. I'm tired, but I can't sleep. My left knee hurts, so I roll over on my right side, but that hurts too. And I can't stand up because I got to use my leg, and I want to push off this one, but that one hurts. So I push off this one, but that one hurts. And it just takes a lot out of people. And you just got to say, are you really up for that kind of a commitment, and figure out whether or not that patient is one of those people that says, good Lord, that sounds overwhelming. No way in hell I'm doing that. Versus are they one of the ones that say, I couldn't care less how bad it is. I only want to do this one time.
Well, yeah. And then you also know those patients with the very high pain thresholds where their knees look like, bomb went off and they're taking Tylenol. Yes. And you say, all right, you're going to do just fine. I just recently, a few weeks ago, did a double knee replacement on a fitness instructor. And she's like a maniac. She's back teaching spin classes, 2 months later, pretty much. And it's amazing. She's doing very well. So you just saw her in the office for her follow-up. And now she's sending all of her students, her spin students to me. So now I have a lot of people who want to go back to doing that stuff. But I tell people anyway that after you do your knee replacement, you're going to be mad at me for about 2 or 3 weeks. I tell them you're going to be angry with me. So this is just how it's going to go. You're going to forgive me after about 2 or 3 weeks, and then you're going to be okay.
Yeah.
So, yeah, I totally agree with you with the double knee thing, and that people want to go around. They figure someone will say yes, and that goes with other things like, and we're going to talk about this later. Patients with BMI of 60, and they say they'll just keep going somewhere else until someone says yes. And I don't know if that's in their best interest.
Well, you discussed obesity. You just brought up obesity in joint replacement, and that was really the next thing I had on my list to talk about. And I think when we talk about these ethical considerations and patient selection, patient screening, things like that, I think I personally think we do a pretty poor job on this as orthopedic surgeons about dealing with obesity. When I hear people talk about this, a lot of times people are just awfully blunt. Well, just don't operate on overweight people. Just don't do it. I was at CCJR one year, it was a long time ago, and they showed a case of this patient that had horribly arthritic knee, significant varus deformity, bone-on-bone arthritis, was like 50 years old, dialysis patient, out of control diabetic, morbidly obese. What do we do about that? And a guy that I really respect a lot, and that I've heard a lot of meetings, said, I'd really have a discussion with that patient on, we probably shouldn't operate on him. And the moderator, to his credit, really went after him. He's like, hold on a second. He's like, that's not a strategy, and that's not a plan. Like, what are you going to do about this? I just really try hard not to operate on it. Yeah, I know you won't operate. Like, he just kept on it a little bit. Mm-hmm. And I thought that was really interesting, because like, not operating is not a plan, and telling somebody that they can't have surgery because they're overweight is not a strategy that really can help them that much. So I try to talk to my patients about, listen, I want to be your advocate on trying to get this surgery done. I want to be a part of the solution, but we can't move forward for this reason, and here are the complications that you're at risk for and why we can't move forward. But here's some solutions that we're going to try to come up with. And so I just want to hear your comments on that, on obesity and joint replacement in particular, and how can we be better about this as orthopedic surgeons than we are now?
That's a really good question. And it's something that is controversial. And as you just pointed out, you could just put a whole bunch of us on a podium and we'll just argue about that all day long. And I tell people those are the taste great, less filling arguments that we have, that we're just going to keep yelling at each other back and forth about. But, obesity obviously is a big problem in our country and internationally in the whole world. And the rate of obesity continues to increase. But that doesn't mean just obesity by itself shouldn't be a reason not to operate on someone, unless it's something that is going to impair the outcome. And it's going to. So in my practice, I have a soft, not limit, but soft flag BMI of 45, where I say, hey, let's try to get some weight off in a healthy way, get your muscles strong, because you're going to have to recover from this operation. But I won't say no. But BMI 50 or over, I say, look, we got to get you down a little bit, but before we do this operation, we got to do it in a good way. There's ways that we can do this now that didn't exist before, and I'll help you and we'll get you plugged in. We have a nurse navigator now that helps us with optimizing patients, and she's basically coordinates all of this stuff to help them get into bariatrics or help them, see the right person to get the weight under better control. And that's, it's been pretty successful. I mean, frankly, there are people who are overweight and very unhealthy. And then there are people who are overweight and pretty healthy. And you can do very well. You can help those people quite a bit by doing surgery on them, especially if they have a really bad joint and you can fix it. But people who are unhealthy and overweight, you have to address the problem. What's underneath all of that? And one of my colleagues, Jim Slover, wrote a lot about metabolic syndrome years ago. And now that's become even more of a hot topic, malnutrition, low albumin. Mm-hmm. So those are the things you can address, make them healthier so that they'll heal and they'll do very well. You do have to maybe adjust how you do the operation. We just published on tibial loosening with and without stems, and finding, a weight, not just a BMI, but a weight that you have to consider adding a stem for some cemented prosthesis, and that's 250 pounds. So, you have to think about doing that and adjusting your technique to make it last longer so you don't have a complication. And then things that you're saying otherwise. I mean, dialysis, you can't change. That's not modifiable. However, you can modify diabetes. And there are a lot of medications that can improve diabetic control. A lot of people, especially underserved populations, tend to have not a more disjointed care. So they're not seeing the same doctor every time they go to the doctor. They may not ever
disjointed.
Yeah, yes, disjointed. No pun intended. But their care isn't coordinated as well, because they may not see the same physician. They may see a physician extender and never see their doctor, but their doctor just signs off on things. So they might not get more aggressive treatment for uncontrolled diabetes or other things that can be controlled. So really getting those people plugged into the right specialist, having them see an endocrinologist.
Yeah.
And that can really change their life. I mean, I've had people come, especially after COVID, when people just stopped going to the doctor, with their A1C at 13, 14. And, I try to get it under 8 to do elective surgery. And then try to keep the control, their glucose control in the weeks prior to and after surgery really tight, so everything heals. But, some of these folks they don't even know what an endocrinologist is.
Yeah.
And they don't even correlate the fact that high A1C may actually make their pain worse. And they don't understand that. I'm like, your blood is not delivering oxygen, it's delivering sugar. Your blood is molasses. It's not doing its job when it's like that. So that kind of speaks to them, and it can make them better. And I've seen a lot of folks get much better, and then it stays better. We published on this, how we have prolonged improvement of A1C after joint replacement.
Yeah, I kind of have a similar approach to you. I tell people, if you're 40 and under, I think you're good. If you're 50 and over, I don't think you're good. I think we're going to need to do something different. When you're in between 40 and 50, that's where we have to think about, where are you trending? Where have you come from? Where have you gone? And what's your medical risk profile look like? If I have somebody with a BMI of 46 that says, I'm as heavy as I've ever been, I can't really do much because of my knee, but I haven't had any luck with losing weight. That's the kind of person I really want to say, you know what, let's get you a bariatrics referral. Let's talk to your primary care physician. Let's understand the implications of your morbid obesity outside of your knee replacement, or in addition to trying to get your knee replaced, versus if I have somebody that said, my BMI used to be 61, I went and had bariatric surgery, I got my BMI down to 38, now it's back up to 44, and I've done everything I can. I've talked to my primary care doctor, I have a nutrition specialist I meet with regularly, and I'm just really struggling to get it below 44. In that case, good job for you for doing all you can to get where we have. Let's roll and get this thing fixed, and hopefully it can help you. A couple things that I think are interesting from a research perspective. You brought up stems and surgical technique, but I also think the other things that are interesting to look at in the literature is, there is a slight increase in infections. There is a slight increase in overall complications, but the idea that these patients can't do well and that they're not going to get benefits from it is just not true.
They improve so much. Their life improves tremendously.
They get a lot better in short order. With exceptions, of course, but I mean, for the most part, I think these patients do just as well. They rehab just as well, et cetera. And even though you have an increased risk of infection and complications, I wish I need to look this up again so I can give the authors credit, but there was a VA study that showed, looking at people that over a BMI of 40 who had surgery, what were their outcomes like versus how many complications that they had. So they could try to figure out a ratio of how many good outcomes would we have avoided if we had denied these people over a BMI of 40 from surgery versus how many complications.
I think it's Brian Springer. I thought it was Brian Springer wrote that.
Yeah, and it was 14-1, 14 good outcomes that you would have avoided for every infection or complication that you would have avoided. So yeah, I realize that, and I agree that there's an increased risk of complications, but there's still patients that can do really well for there, and you have to put it into context. It's a relatively slight increase that, under the right circumstances, I still think we can do better for these patients and get some good outcomes with them.
No, you're right on with that, and it's true, and that speaks to what in the article that we just published, the concept of the informed consent decision, and how do you talk to a patient about what's going to happen to them and what you expect to happen to them and what their risk is. Not many, we all say our speech of what your risks are, but very seldom do we actually really personalize those risks.
Yeah.
To say, oh, look, if I fix your knee, you're going to go from a 10 out of 10 pain to probably maybe a 2 or 3 out of 10 pain.
Yeah.
But your risk of having a heart attack is really high because you have your cholesterol out of control and you're having angina and all this stuff or whatever. And so we need to probably get that risk down, because going from a 10 to a 3 may sound great, but if you have a heart attack and die, who cares about the pain?
I want to do a nice knee replacement for you so it looks good in the morgue.
Definitely. Exactly. So really, having a tailored conversation. And sometimes you don't need to be the one to do that. You can have someone else on your team do that for the patient. Like, we're going to have a risk discussion because, we've calculated your risk and here's what we have. And there's a lot of value to that. But, risk calculators, there's a lot of fallibility. We wrote just an ICL chapter about that recently, about how to calculate risk. And there's a whole bunch of different ways to do it.
Yeah.
But having a conversation. Now, one of the patients that we presented in this article was a younger person who had AVN of the femur and tibia. Mm-hmm. And the surgeon, they had seen a bunch of different surgeons and nobody really offered anything except for a sports surgeon who had a few patients who had an improvement with a certain arthroscopic technique and decompression. And the patient was high risk. So how do you talk to that patient? Like, okay, I've done this a few times and it's worked okay, but there's really no evidence that it's going to work. Plus, your risk is very high. So I don't know that the risk balances out with the pros, with the benefits of it. So being able to talk to patients that way and saying, look, the chance that we're going to make you better is not very high, but the chance that something could go wrong is pretty high. So yeah, this surgery exists, but
yeah, I found that fascinating as well. And that's something that I think really gave a lot of depth to this article, was when you talked about, is there really true consent? I think it was the first case you talked about, and one of the paragraphs ended with, is there really true consent in this scenario? And I really, thought long and hard about that, because it really is a perception. You talk about a patient's risk profile, and they're perceiving their own consent based on what they're being told. So it kind of leads into my next question. You talked about palliative care. And so I guess 2 questions. One relates to what you were talking about, and you have these risk profiles, these risk calculators, which are great. So my first question is, how does that conversation go? I know you said you don't necessarily have to be the only one doing that. You can have people in your office. So are there go-to resources, whether you're trying to control diabetes or trying to control obesity or smoking cessation or what have you? So I guess we'll start there. Are there resources that you have found that are successful? And just really talk in general about having those, let's be honest, they're difficult conversations with patients when, like you said, if their perception of success is whatever, and you deem that you need to really address some serious issues before surgery. So I guess how's that conversation go, and are there any resources that you have found success with?
Well, yeah, that's a big question. But we, at our institution, we have a perioperative surgical home or perioperative surgical coordinator. She's a nurse, and she helps with patients who need substantial optimization. And we'll have a conversation and say, look, you have a lot of these factors that we can modify before surgery. And I think we should do that if we can, because this is elective surgery. It's not a burst appendix where you have to do surgery right now. So why not make it safer for you if we can? So I offer them to see that navigator, and they help get them in with specialists, and we do the best we can. And I see them again, and then we see if we've gotten anywhere, and then we can book surgery. But I think to the question from the article, there's high-risk patients that are elective patients, and we now have a team of people who reviews these high-risk patients when they're cases, and they're flagged by the perioperative team when they come through we do everything on computer. So when it comes through the computer, this person has all of these flags, so that the committee looks at the patient and sees if they meet criteria to be very high risk. And then we talk to the surgeon and say, look, have you tried X, Y, and Z? I noticed you only saw them once in the office. maybe you can try some other things with this patient to see if they can't get in a little bit, healthier before the operation, because we really don't want a bad outcome. And most of the time when we review those things, the surgeon says, wow, you know what? I wasn't even thinking about that. And that's a really good idea. I'm going to let them know. And we're going to try. I'm going to see them again in a couple months. We're going to get them a little bit better and healthier before surgery. And then the other side of that is if you're in the office and you see someone who's really, really high risk, but they might benefit from an operation, you can say, look, I don't want to book surgery right now because your risk seems really high, but we do have a committee that reviews these more complex surgeries and patients. So what I'm going to do is I'm going to put your case in and we're going to present it to this committee, and then we'll see what they say. So it helps the surgeon, because the surgeon doesn't need to be face to face with the patient saying no. They can say, look, you know what? I have empathy for you. I understand that you're in a bad situation and it hurts so much and you want me to fix this, but there's a lot of risk here. And I think we need to unpack this before we proceed. And we have a process here that we have to go through with patients that have high risk. And we're going to go through that process. So it takes the onus off the surgeon in that face-to-face encounter a little bit.
As with most things, I think these discussions are just all about communication, and to boil it down even more than that is, I think about this with the obesity discussion a lot. Just don't be a jerk. Like, it's really as simple as that. Like, don't tell someone, well, you're too fat, so I'm not operating on you. That doesn't help anybody. All that's going to do is you're never going to see that patient again, because they're going to leave there thinking Dr. Benner's a jerk. They said this to me, and I can't believe that they said that. And there's no chance they're ever coming back. Versus if you approach it as, I want to be part of the solution along with you. I understand this is difficult. Like, there's millions of people in our country that are struggling with this, but I'm not doing my job if I don't understand and share with you the risks that we're up against. And I don't want to make it worse. As much as you think it can't get worse, it can get worse. And I would hate for us to do a surgery, for us to have a complication and then get done with it in the end and say, gosh, did I really need to do this, despite all these risk factors. So and I think this discussion and all these considerations are ones that we all should be having on a daily basis. And I'm sure this was really educational for you writing this to educate the rest of us. So, talk a little bit about that as we start to wrap up here. How did writing this manuscript make you a better physician? How did it make you better at what you do?
Well, that's a very good question, because when you write a paper like this that explores ethical conundrums and informed consent and, what do patients perceive as risk? What resources do you have as a surgeon when you face these very complex problems? It helps me become more aware of it. And now when I speak to patients, especially higher risk patients, in terms of informed consent, I try to put it in layman's terms and say, look, your chances of getting much better from this operation are 7 in 10. So 7 people are going to do great, 3 people maybe not so great, but your risk is 9 out of 10. So, maybe we need to bring that risk down a little bit to make this surgery worth it. So they understand that a little bit better. The second thing is having other resources that you can say, look, let's try some other things. Let's see if we can get you to see some specialists. Let's see if we can coordinate your care and get you better optimized. One thing that we haven't talked about yet is, I said, we have that committee outside of the hospital for patients who are not inpatients, but we do have a team in the hospital for when patients have there's an ethical challenge with a patient. And if you aren't sure about what to do for someone, you can call on them. And it is a team that's an escalation team that can review the care of the patient and help you make a decision. So if a family is demanding a surgery and you say, this is really too high risk, that team can support you or tell you, no, you know what, you should proceed. So you can phone a friend basically and have some help when you make these very tough decisions as an outpatient or as an inpatient for the patients.
Last question. I think another important part of this, and this is going to sound maybe a little less compassionate than what I've talked about before, but I think as surgeons, we have to empower ourselves to say no. There are just some patients that say, doctor, we got to do this. Like, you don't understand how bad I'm hurting. You don't understand how bad this is. Yeah, I do understand. I sympathize with you. I'm sorry that it's like this, but I just don't know that I'm going to help you. And there have been times that I've just had to break it down and say, listen, unfortunately, the answer is no. I'm not doing this operation. We have to be able to buy into one another, that we're ready to take this journey together. And for the reasons that I've already articulated, I'm just not willing to do it. So unfortunately, I'm sorry that we're not going to agree on this, but the answer is no. And I think it really bothers me when I go to meetings and people say, well, I kind of got talked into doing this case. I was working on non-surgical treatment, weren't getting any better, and I finally just kind of gave in and did it. And I think we need to give ourselves as orthopedic surgeons a space to say no when we think it's appropriate.
Well, and that's this whole point of this, is that it's okay to say, look, either this is too high risk and I don't feel comfortable doing it. And you're allowed to say that, because as long as that patient is taken care of, that's the goal. But feeling comfortable saying that you're declining surgery is difficult, and it's hard, but you should be allowed to do it if you feel that there's something that's dangerous about it, or that they're not going to benefit from it. I have someone now I've just been shaking my head. He's a guy with terrible knees. I mean, it's terrible, but has cognitive problems. Comes in 2 hours late, goes to the wrong place, goes to X-ray and leaves because he doesn't remember he has to come down to the office afterwards. And he lives by himself, has someone helping him, but that person isn't very helpful. And he's terrible pathology in the knees. But, I can't justify doing surgery on someone that may not remember to take their post-op VTE prophylaxis. Even if I send him to a rehab place, he's going to go home eventually and then not remember something. I sent him to geriatrics to have them evaluate him. They did cognitive testing, and, geriatrics is a tremendous resource for older patients, especially to go over people who have polypharmacy. Everyone's piling medicine onto these old people and nobody takes any of them away. So like, oh yeah, this person's really confused because they're on 10 different medicines when they should be on 2. So they help with that stuff. So, but it's still not bad. And the guy keeps calling and wants surgery, but I don't, I feel so scared. I'm afraid something terrible is going to happen.
Yeah.
And that can happen. Yeah. And if you have your gut says something is wrong, you should listen to that gut, especially if you've been in practice a long time.
Absolutely.
Because that means something is bad.
Yep. For all our listeners out there, if you want to check this out, it's the Orthopedic Forum on Journal of Bone and Joint Surgery in press coming up soon. Dr. Claudette Lajam is the first author on this paper from NYU. Thank you so much for joining us tonight. It's been a really interesting conversation. I feel like I've really learned from this. I hope you and our listeners have as well. And we really appreciate you coming on.
Thank you so much for having me. It's been an absolute pleasure and great talking to you.
Great stuff. As we talked about before, we're all over social media. We're on Twitter and Instagram at the SKC Podcast. We have Facebook and YouTube pages for the Shelbourne East Center Podcast. You can email us comments or questions at the skcpodcast@gmail.com. Check out our previous content. This is episode 42, so we've got a lot of previous content you can check out. If you like what you hear, give us a 5-star review and share it for other people to see as well. So thank you for joining us, and we'll see you again next time on the Shelbourne East Center Podcast.